Hello everyone and welcome to this explainer. I am so thrilled to have you here today. We're going to tackle a topic that, honestly, sounds incredibly intimidating at first, but is absolutely fascinating when you break it all down. We're talking about mechanical ventilation. Now, we aren't just going to look at this as some complex machine with a bunch of tubes and blinking lights. No, we're going to decode it by looking at it as a life-saving patient journey. We'll track the exact clinical steps taken to assist someone who literally can no longer breathe on their own, right through to that triumphant moment when they finally can. So let's just jump right in.
Here is our clinical roadmap for today. 1. Oxygen escalation. 2. Ventilator types. 3. Non-invasive modes. 4. Invasive modes. 5. Alarms and safety. And 6. The weaning process. Just keeping this map in the back of your mind is really going to help lower the cognitive load as we get into some of the medical acronyms later on.
Section 1. Oxygen escalation. Failing to breathe. Okay, let's dive into this by establishing the core problem. What actually brings a patient to this point? Well, it all starts when a patient is failing to breathe adequately on their own. Their respiratory system is just struggling to maintain the right balance of oxygen and carbon dioxide in the blood. As you probably know, normal human oxygen saturation should ideally sit somewhere between 95 and 100%. If a patient's oxygen drops below that crucial 95% threshold, they need immediate intervention. Now, there is one really important clinical exception to keep in mind here. If a patient has COPD or chronic obstructive pulmonary disease, their target saturation is actually much lower. It hovers right between 88 and 92%. But for your standard patient, slipping below 95% triggers the very first stage of our journey, oxygen therapy.
The clinical response is always a step-by-step escalation. We don't just jump straight to the machine. Step 1 is the simple face mask. This is the one you always see in the movies, delivering about 5 to 8 liters of oxygen per minute. Now, if the patient's saturation doesn't climb back up with that, we move to Step 2, which is the non-rebreather mask, or NRBM. This pushes 10 to 15 liters per minute, and it delivers the absolute highest concentration of oxygen possible through a basic device. But what if the NRBM still isn't enough? Well, that's the definitive sign that it's time for Step 3, the ventilator.
Section 2. Ventilator types, artificial machines. When basic oxygen masks fail, we have to rely on artificial devices designed to carefully regulate and maintain a patient's breathing pattern.
We generally categorize these ventilators into 4 main types based on exactly how they operate. First up is the pressure cycle, which delivers air until a specific preset pressure is reached in the lungs. We see this a lot in post-anesthesia care. Second is the time cycle. This one delivers air at strictly preset time intervals, totally regardless of the pressure. Third, the volume cycle, which pushes a very specific preset volume or amount of air into the patient. But the fourth is the modern marvel, the microprocessor. This is a brilliant robotic standard that uses automated computer systems to dynamically adapt to the exact physical demands of the patient's body in real time. It's a total game changer.
Section 3. Non-invasive modes. No intubation needed. So now that we know the machines, let's talk about how we actually connect them to the patient. The first stage of mechanical help is non-invasive ventilation, or NIV. And as the name suggests, this requires absolutely no endotracheal intubation. We just use a tightly sealed facial or nasal mask.
The core mechanism behind this whole stage is positive airway pressure. To visualize this, think of the airway like a heavy door. A vacuum, or negative pressure, would be like trying to pull the door open. Positive pressure, on the other hand, is physically pushing that door open. The machine is literally using forced air to push the patient's airways open so that essential gas exchange can happen.
Under this non-invasive umbrella, there are 2 primary modes you are going to see in a hospital. The first is CPAP, which stands for Continuous Positive Airway Pressure. This one delivers a single, continuous, unchanging stream of pressure. The second is BiPAP, or Bi-Level Positive Airway Pressure. So instead of one constant pressure, BiPAP utilizes 2 different levels. IPAP, which is the pressure applied during inspiration or breathing in, and EPAP, which is the pressure applied during expiration or breathing out.
Let's anchor this theory in a real clinical scenario to understand exactly why a nurse would choose one over the other. Imagine a patient whose blood pH has plummeted to an acidic 5.0 simply because they are retaining massive amounts of carbon dioxide. To fix this, you have to help them breathe out that trapped gas, so you would increase the EPAP, the expiratory pressure, to forcefully push the CO2 out of their system. Conversely, if a patient has a normal pH and normal CO2, but dangerously low oxygen, well, the problem isn't getting air out, right? It's getting air in. In that case, you would crank up the IPAP, the inspiratory pressure, to help force oxygen into the lungs when they inhale.
Section 4. Invasive ventilator modes, endotracheal intubation. But what happens when the airway is physically blocked, maybe by a tumor or heavy secretions, or the patient is comatose and completely unable to breathe at all? Well, that's when we escalate to invasive ventilation, which requires intubating the patient with an endotracheal tube.
Once the patient is intubated, we have a few specific modes to choose from. The most rigid of these is controlled mode. In this setting, the machine takes 100% control of the breathing process. It actually blocks any spontaneous effort from the patient. Basically, the machine becomes a total control freak. And while this is incredibly effective, it is strictly reserved for patients who are comatose, deeply sedated, or otherwise completely uncompensated and unable to do any of the work themselves.
As the patient starts to wake up or recover, controlled mode actually becomes a problem because it literally won't let them breathe on their own. That's where assist control comes in. The machine still has a preset volume it's going to deliver, but if the patient wants to take an extra breath, the machine assists them. However, there is a major risk here. If the patient starts taking way too many breaths on top of the machine's scheduled breaths, they can blow off too much carbon dioxide, and that leads to a really dangerous condition called respiratory alkalosis. To solve this, we use the absolute gold standard for recovering patients, SIMV, or Synchronized Intermittent Mandatory Ventilation.
This brings us to a beautiful analogy that I think perfectly demystifies SIMV. Think of it exactly like a parent holding the back of a kid's bicycle. The machine essentially says to the patient, hey, you pedal as much as you can. Take whatever breaths you are able to take on your own. But the moment you stumble, the moment you don't take a sufficient breath, I am right here to catch you and deliver the rest. It so brilliantly supports the patient's own respiratory muscles without overpowering them. Section 5. Alarms and Safety. Troubleshooting alarms. With the patient securely on the machine, our priority shifts immediately to safety. These are incredibly powerful devices, and nurses rely heavily on critical alarms to ensure the patient isn't being harmed. First and foremost, we have to keep a strict eye on the pressure. If the ventilator pushes air with a pressure exceeding 15 centimeters of water, we are officially in the danger zone. Exceeding this limit dramatically increases the risk of barotrauma. Barotrauma simply means pressure-induced injury, which in this context means a literal rupture of the lung tissue. This is an absolute emergency. To help us prevent those kinds of disasters, the machine uses two main alarms. If you hear a high-pressure alarm, it means the machine is facing resistance. Something is blocking the pathway. It could be a buildup of secretions in the airway, maybe the patient is biting down on the tube, or there could be a physical kink in the plastic tubing itself. On the flip side, if you hear a low-pressure alarm, it means the machine is pushing air and feeling no resistance at all, and that means there's a leak somewhere or the tube has completely disconnected from the patient.
So here is the absolutely crucial takeaway. This is the ultimate golden rule of nursing when dealing with ventilators. When that alarm sounds, you do not look at the blinking lights on the screen. First, you check the patient. You look at their chest, their color, their distress level. Only after you have assessed the human being do you turn your attention to check the machine. Always, always the patient first.
Section 6. The Weaning Process. De-escalation support. Finally, we reach the most triumphant stage of the entire journey. The patient is recovering, the lungs are healing, and it's time for the weaning process, the careful, systematic de-escalation of mechanical support.
We slowly step the patient off the machine to rebuild their strength. We start them on that SIMV mode we talked about earlier, acting as the parent holding the bicycle. Once they master that, we move them to a T-piece. This is a small tube attachment that supplies oxygen, but forces the patient to do all the physical work of breathing entirely on their own. Once they prove they can handle the T-piece, we remove the breathing tube altogether, a process called extubation, and step them down to standard oxygen therapy via face mask. And the final victory? Disconnecting the oxygen entirely and watching them comfortably breathe standard room air.
And just like that, we have walked through the entire journey of mechanical ventilation. From the moment oxygen drops, right through the complex web of invasive and non-invasive modes, all the way to breathing room air once again. It's an incredibly fascinating intersection of human physiology and brilliant engineering, isn't it? Thank you so much for joining me on this explainer. I really want to know, what other complex medical marvels should we decode next? Let me know, keep learning, and I'll catch you next time.